Now, without further ado, we are going to kick off this amazing event with an incredible presentation from two individuals from the National Kidney Foundation. We have Kelli Damron, who is a licensed clinical social worker who has worked in nephrology for over 15 years, first as a social worker in an outpatient dialysis clinic, and then since 2011 with the National Kidney Foundation in her current role as Director of Patient Engagement at the National Kidney Foundation. She is responsible for ensuring that the voice of kidney patients and their families is integral to all that NKF does, internally and with external partners. She is joined with Marissa, Argentina, who is also a licensed social worker who has been in the field of nephrology since 2010. She has worked with the National Kidney Foundation since 2015 and has been working on the NKF Peers program since 2017. She is currently the Patient Programs Director at the NKF, and she has previously worked as a dialysis center social worker in Bronx, New York. Marissa and Kelli, thank you so much for your time today. Looking forward to your presentation. The floor is yours.
Thank you so much, Emma. We are thrilled to be here today. We are going to give an update on insurance and some of the basic information to know and to consider if you are getting ready to start dialysis or have started dialysis. We will make sure we have time for questions at the end. Marissa, do you want to say hi quick?
Hi, thanks so much for having us here. I'm looking forward to giving this overview, and hopefully you'll learn something new about insurance for this year.
I think we do every time we put this presentation together. So next slide, please. So as I mentioned, we're going to talk a bit about the different types of insurance. We'll define some of the common terms, but please, if you hear us using a term that we haven't defined, feel free to ask us at the end. We'll talk a lot about Medicare and all the different aspects of that, including the differences between original Medicare, Medicare supplements, and Medicare Advantage plans. And also some of the nuances of immunosuppressant Medicare coverage. Next slide, please. So to kick us off, just to kind of set the lay of the land, to overview the main types of health insurance that are available. So there's Medicaid, employer group health plans, individual plans, and then finally Medicare. Medicaid is a state-run program, so we'll talk a little bit more in depth about this, but usually the plans are called different things in different states, but if you Google your state Medicaid plan, you'll be able to find what the more common name might be. And this is typically for people who are low income or uninsured, children as well. So you can look at what the income requirements are. Again, this all varies by state. So it's really important to find out what the nuances are in your state there to see if you may qualify. An employer group health plan is very much how it sounds. So if you or your spouse are employed by somebody, so they would offer insurance as your employer. Individual plans are not through an employer, but plans that you can buy either through the marketplace or through a private insurance broker. And then finally, Medicare is kind of the counterpart of Medicaid. As Medicaid is a state-run program, Medicare is a federal insurance program that is traditionally offered for people who are over 65 or at any age if you meet disability criteria. And then uniquely, ESRD is end-stage renal disease. You might hear ESKD now, end-stage kidney disease. This is kidney failure. So people who need dialysis or have a transplant are also eligible. This is the only disease that grants you eligibility for Medicare. So really unique and also fabulous that this is available for kidney patients. Next slide, please. So again, we're going to dive into this a little more later as well, but to set the stage, there are Medicare supplements, which are called Medigap plans often, or Medicare Advantage plans. When we talk a little bit more about Medicare later, I'm sorry, traditional Medicare does not cover everything. There are some costs that only cover, say, 80%. And so many times people will buy one of these supplemental plans to cover the costs that are not covered by traditional Medicare. Medicare Advantage, on the other hand, is offered by private insurance companies. So these are really offered as an alternative to original or traditional Medicare. And those can have various things that they cover, but typically will cover more than original or traditional Medicare. And you need to look at them more similarly as you would individual insurance plans. And again, we will say more on all these later, but to set the stage. Next slide, please. Again, some common insurance terms. Deductible is where I'm going to start, even though it's on the far right, but this is the amount that you have to pay for your healthcare medications before your insurance kicks in. So this can vary depending on your plan. So always important to see what the deductible might be, what you would have to be responsible for before your insurance would cover anything. Coinsurance is the amount that you may still pay after meeting your deductible. So coinsurance is something we're seeing more frequently, and typically that's seen as a percentage. So you would have maybe like a 20% coinsurance. So whatever the cost is of your healthcare or your medication, you would have to pay 20% of that. So that can, as you can imagine, get quite costly if the cost of the service or the medicine is very high. So something to think about there, even if it does seem like a low number, like 10 or 20%, that can be a lot. A lot of a lot is a lot, is what we always say, right? Copayment or copay, I think, is something people are more familiar with, particularly around medications or when you go to the doctor and maybe have to pay something to see the doctor. That's typically your copay and is a fixed amount. Typically, it can be different for primary care versus specialists. And again, that would be kind of laid out in your plan's information. And out-of-pocket maximum is the most that you'll have to pay during a year. Typically, it's through the insurance year. And once you have reached that out-of-pocket maximum, the amount that you personally pay out of your pocket, 100% of the services would be covered after that. Next slide. So again, we'll dive a little deeper on all of these. Medicaid, as we mentioned, is a state-run insurance program. This is income eligibility, and as I mentioned, it is different in every single state. So you have to see what the income and asset requirements are to make sure that you meet them in your state. For certain states, those income eligibility requirements will be higher, and in other states, it's far lower. You can find your program at medicaid.gov. And you can also apply through healthcare.gov and to determine there if you're eligible for any subsidies, so any discounts that you might be eligible for based on your circumstance. Next slide, please. Private insurance, as we talked about, employer group health plan is one of them, and then buying individual insurance plans through a marketplace would be the second one. So if you are employed or your spouse is employed, you can find out what the options for coverage are, talk with your human resource department to see what the differences between the plans that they're offering are. Sometimes there's a high deductible or a low deductible one, and see if you can figure out what might meet you or your family's needs best. Next slide. So you can buy them through an insurance broker. I think that's happening less and less, but that is still an option. The Affordable Care Act plans, you can see what you are eligible to buy through there. So if you are not employed and are not eligible for Medicaid, the state health program, this is a great place to go to see what options are available to you. Typically that is based on your income still, so you can see the costs there. And again, see if you're eligible for any subsidies with Medicaid. So even if you think you're not eligible for Medicaid, I think this is a great website to start on. If you have no insurance, go there and they will walk you through the options that are available to you. Next slide. And Medicare, the big one for kidney patients. So this is a federal entitlement program. An entitlement means that you are eligible simply based on meeting certain criteria. So once you hit 65 in this country, you are eligible for Medicare. If you meet certain criteria for being disabled at a younger age, you would qualify. And this comes with caveats that you have to have paid into the system enough. So if you or your spouse have paid taxes, basically, you'll see your Medicare taxes similarly to Social Security taxes on your pay stubs. They count how many years you have worked and translate that into these work credits. So this is something you can look up and find online how many work credits you have. But typically, if you have worked over the years, this is something you're eligible for once you reach 65 without a problem. And like I said before, it's really unique and incredible that we do have this protection for people who have kidney disease, who need dialysis or a transplant. So it is only eligible once you need dialysis or transplant. It's not, you would not be eligible if you're in the earlier stages of CKD. So that is a caveat to keep in mind as well. Next slide, please. So there are 4 different parts of Medicare. Part A is the part that covers hospitalizations or anything associated with a hospital visit. Part B is called medical insurance, and it often covers outpatient visits. And this is where dialysis treatments fall under. Because dialysis treatments are happening in outpatient clinics, Part B is often paying for those. This is also where immunosuppressants fall. Which we'll talk about a little more later because that is unique. Because Part D, all the way to the right, I see the N got moved there by accident, but the Part D is the drug coverage or medication coverage. So it is unique that immunosuppressants are covered under Part B, but everything else that you would take for a medication is more or less covered under Part D. And Part C is the kind of tricky part, which is the Medicare Advantage plans, which we talked briefly about, are those run by private insurance companies that offer a different approach or solution to Medicare. So like we said, there's some parts of Medicare that don't cover everything, and Medicare Part C or Medicare Advantage plans try to offer a more holistic approach. Sometimes they'll include dental insurance, for example, or cover the parts of Part A or Part B that are not covered. I'm gonna look through my notes very quickly to make sure I said everything I wanted to say here. But Part B, when we talked about the parts that aren't covered, typically that covers 80% of outpatient visits and immunosuppressant medications. So when we talked about co-insurance earlier, we said 20% of a lot is a lot. Well, it's similar here. So if the cost of dialysis treatment is very high or the cost of immunosuppressant is very high, that 20% co-insurance can be quite costly for folks. And that's where a lot of people are looking for a supplemental plan, or perhaps looking at Medicare Advantage plans to be a solution to cover that kind of deficit there. Next slide, please. So Part A is free. Remember, that covers hospitalization. So that's something that you're entitled to that would cover for free. Unless I think you make a lot of money, then there might be a fee for all of this. But for most people, this is true. Part B is $174.70 a month as of this year. This does change year to year, so this is something to look at, but typically only changes by a few dollars. And Part D, this is also an open kind of marketplace where patients have a choice of the plans. And so this is where you can look and start to assess deductibles and co-insurance and co-pays and try to see what would work best. You can, I think we have the link at the end where you can go on and kind of plug in the medicines that you take and see what might be a good plan that would cover you well. Some people are willing to pay a little bit more upfront in a monthly premium to have better coverage of the medicines themselves. And other people maybe have medicines that they know are not too expensive and are willing to take a chance and to kind of have a higher co-insurance. So those are all things I think people need to think about on an individual basis, but make sure that you are looking at those things when you are choosing a plan and thinking how that might impact your kind of monthly expenses. As we mentioned here before, just also pulling out that unique feature that Medicare Part B does cover the cost of immunosuppressant medications. And so that does leave 20% co-insurance for people to pay, which again can be quite costly and something to consider when people are preparing for having a transplant. Next slide, please. So when does Medicare coverage start? start? Medicare coverage starts, if you start dialysis in center, it will start in the 4th month of your treatment. So typically when you start dialysis, you will apply, your social worker or insurance coordinator at your center will help you apply, and that will become effective in your 4th month. If you start home dialysis, so that's home hemodialysis or peritoneal dialysis, then insurance starts, Medicare insurance starts in the 1st month, and that's to incorporate and cover the training and everything associated with preparing to go home. For transplant, if you do not previously have Medicare, it would start the month that you're admitted into the hospital for a kidney transplant, and for any healthcare prior to the transplant would be covered within the following first 2 months. So again, if you have a preemptive transplant, it would be effective the month that you are entering into the hospital, and it would retroactively pay for the costs associated with the workup. Next slide, please. So what if I have private insurance through an employer, so employee group health plan, when I become eligible for Medicare? So this is a great question. So you can apply for Medicare at any point in time in the first 30 months that you become eligible without a penalty. So you always have the option to apply for it or not, I guess is the first thing to say. The question is if you don't apply for Medicare, when you become eligible, then you do face a risk of getting a penalty later on down the road if you decide you need or want Medicare at a later date. So typically, I would say most people are encouraged to sign up for Medicare, even if they have other insurance coverage, as it will act as a secondary insurance as needed. Some people may find that frustrating if it's not covering something in the moment that you have it, if your employer group health plan, for instance, is very good. But it's important to kind of have it in your back pocket if down the road you think you will need it to help you cover any sort of kidney-related expenses, whether that's dialysis or transplant. So if you apply within the first 30 months of your eligibility, there's no penalty. If you apply for only Part A, so that's the free part, and not Part B, the part you have to pay for, you may face a penalty. And you can only enroll in the future after your original eligibility period during general open enrollments, which is every year, January through March. Part B would then be effective in July of the year that you apply. So you may experience a gap in coverage if you are waiting to do so later on or realize later on that you need to. So there's also a coordination of benefits period. So if you do have employer group health insurance and you start dialysis, your private employer group health plan would pay for your dialysis treatments for the first 30 months. They would be considered the primary payer. After that, if you're eligible for Medicare, it automatically will switch and Medicare will become the primary insurance. Now, it's important at that point to know that your employee group health plan will still remain if you continue to work or your spouse continues to work for that company and you buy those benefits as the secondary insurance. And when we talk about Medicare having that 20% not covered and only covering 80% of dialysis treatments, keeping your employer group health plan as your secondary insurance would help to offset those costs. So this will happen regardless. Next slide, please. What if I have private insurance through the Affordable Care Act when I start dialysis? If this is true, then you can choose to apply for Medicare or keep your individual insurance plan. You cannot have both plans here. With your employer group health plan, you can. With an individual plan through the Affordable Care Act, you cannot. The Affordable Care Act is really meant as a safety net for people who have no other insurance options. And so once you become eligible for Medicare and apply for it, you would no longer be deemed entitled to the Affordable Care Act health insurance plans. So we created this worksheet because there are, as we talked about, kind of costs associated with both and pros and cons benefits to both sides. So we can share that. I believe we have that linked at the end as well. If you do apply for Medicare, you will lose any subsidies that you had been receiving through the Affordable Care Act marketplace. And if you choose not to enroll in Medicare when your kidneys fail, when you start dialysis or have a transplant, then you will likely face penalties and higher premiums later when you enroll late. So there's definitely a lot to consider here. I think this is a unique situation. And again, that worksheet at the end that we can share, I think is helpful, and certainly happy to answer additional questions if we're able at the end on this. Next slide, please.
Okay, so I'm going to talk a little bit about what happens when your Medicare coverage ends. So in the past, your Medicare coverage would end 36 months after your transplant if you're only eligible for Medicare because of your kidney disease. However, this changed through the advocacy of the National Kidney Foundation and other partners in the kidney community. And since January of 2023, kidney patients can now keep their immunosuppressant Medicare coverage for the life of their transplant. It is important to note, though, that Medicare will only cover those immunosuppressant medications after that 36-month period. All other Medicare benefits will expire 36 months after the transplant if you're only eligible due to that kidney disease qualification. The coverage for immunosuppressant only is really just a safety net for those who don't have any other insurance. So it really is ideal for you to have comprehensive insurance through another source, either through Medicaid, an employer, or the marketplace. Next slide, please. So immunosuppressant medications are medications that you take after your transplant, and they're really essential to have covered after your transplant. Remember, they're covered under Part B if you have Medicare Part A at the same time. And just remember that Part B only covers 80% of the cost of these medications. So you may need to have additional insurance to avoid those high out-of-pocket costs. Next slide, please. So you can enroll or change plans from October 15th through December 7th of each year. Coverage of medications will vary from plan to plan, so it's really important to check and make sure that your medications are covered before you enroll each year. And each year, those plans may change which medications they're planning to cover. So please don't just automatically enroll in the same plan that you may have been through in the last year. Things can change year to year. And again, you can compare those plans through Medicare by visiting their website or calling 1-800-MEDICARE to have someone help you choose the plan that might be best for you. Next slide, please. Applying for extra help. So if you have Medicare and you're still having trouble paying for your prescriptions, you can apply for something called extra help through the Social Security Administration. There is an income and asset limit based on if you're single or married to be eligible for that extra help program. Income and assets are defined by things like real estate other than your primary residence, bank accounts, stocks, or bonds, and there's a full list of assets on the Social Security website, or you can find out more by calling the Social Security Administration. Next slide, please. So now I'm going to talk a little bit more about those Medicare Supplement or Medigap plans. Again, those plans are supplemental insurance policies that people often buy to help cover additional costs through their Medicare coverage. Remember, again, Part B only covers 80% of those dialysis and immunosuppressant costs. And like Kelli was saying, high cost of something is still a small percentage, is still a lot. So Medigap plans will help cover the other 20%. But these plans are mostly aimed at people who are over 65. There might be some plans that are offered to those who are under 65 as well. And you can contact your state insurance health program to help what's available in your area. And we'll have those, as you can see, that link will be here, and I believe this will be supplied to you after the call. Next slide, please. So Medicare Advantage plans are a type of Medicare plan that's offered by a private insurance as an alternative to original Medicare. And these are also known as Part C, Medicare Part C. And they provide all the Part A and Part B benefits and can often offer prescription drug benefits as well, and other things such as transportation or dental. It really depends on each plan. And Medicare Advantage premiums are often less than those of Medigap plans. So next slide, please. But let's talk a little bit more about those Medicare Advantage plans. While they can offer many benefits, it's still important to consider the potential hidden costs, such as deductibles, copays, lifetime coverage limits, and other out-of-pocket costs. There may also be limitations on which providers you can see in network with Medicare Advantage plans. It is important to know if your preferred healthcare providers, such as your dialysis center, your transplant center, and any other providers that you might see regularly, are in network with the plan that you choose. Otherwise, there might be higher costs to see those providers if they are out of network. If you do enroll in a Medicare Advantage plan and want to switch back to original Medicare, you might not be able to get a Medigap plan, which could leave you without that secondary insurance to cover that 20%, which isn't covered by original Medicare. So it's really important for you to do your research and determine if a Medicare Advantage plan is right for you. Next slide, please. So you might be able to get some help for Medicare premium costs through something called a Medicare Savings Program. There are 4 listed here, and each program has slightly different benefits that they help cover. For example, some will help cover copays and premiums, and some will just cover the premium costs. And again, these are based on income and asset limits, such as much like the Extra Help program that I mentioned earlier. So if you do qualify for one of these first 3 programs here, you are automatically qualified for that Extra Help program from the Social Security Administration that I discussed earlier, that also helps with that Part D medication costs, the Part D plans. And you can find out more about Medicare savings plans on medicare.gov. So next slide, please. So if you are being evaluated for a transplant, you will definitely need health insurance. And transplant centers, they really want to make sure that your insurance is stable going into the transplant. And transplant centers may have a financial coordinator to meet with you to make sure that your insurance is going to be able to have adequate coverage for the time before, during, and after your transplant. And they want to make sure that you'll be able to afford the medications after transplant, as many of them are very expensive. And if you are someone who is receiving premium coverage through the AKF HIP program, you are eligible for coverage through that program after your transplant for the remainder of the coverage plan year. But you must have been receiving coverage through that program for at least 3 months prior to be able to continue that premium coverage program enrollment. Next slide, please. And if you're curious about insurance and living donation, if you know someone who might be wanting to be a living donor, sometimes it's good to know about what insurance coverage they might need. So all workup costs should be covered by the recipient's insurance. If someone is looking to become a non-directed donor, they don't have someone specifically, their workup costs will initially be covered by the transplant center. However, living donors do often living donor transplant centers will often want living donors to have their own health insurance in case the transplant center discovers something that does require medical attention outside of the scope of becoming a living donor, since the living donor workup is very intense. And that transplant center may want to make sure that they're able to get the care that they need before, during, or after the donation as well. Next slide, please. So we have some resources available. We do have, again, that worksheet that Kelli was talking a little bit more. We have a great brochure about insurance. We have information about comparing those Medicare plans, and lots of links to resources here on the right. So these should be available to you after the call is over. So next slide, and I think we have some time for questions.
Thank you, Marissa and Kelly. And Kelly, I see you have been hard at work answering some of these questions here. I wonder if you'd be willing just to address some of the ones that you've answered, specifically around questions on penalties for not applying for Medicare when you become eligible, if you do not have enough hours, or if maybe you're a pediatric patient.
Sure. So I had to look up, honestly. So there are penalties, as we said. It looks like it depends on the part of Medicare that you're late enrolling in. So Part A is a 10% penalty on your monthly premium for twice the number of years you are delaying enrolling. Part B is a 10% penalty for each year you delayed enrolling. And this penalty is lifelong. I don't know why it doesn't say that for Part A. So there's some nuance here for sure. You would want to look into this. And Part D is a penalty of 1% of the national base premium for each month you delayed enrolling. So it's rounded up to the nearest 10 cents and added to your monthly premium. So that sounds like a lot less. Again, I think the challenge around this really is for people who have employer group health plan, they don't want to pay the Part B because Medicare is not paying anything those first 30 months. And I think it feels sometimes as a burden, right? It's another cost for something that you're not using directly. But then ultimately when it switches to being the primary insurance and you need it, it's hard to go back on that. So you can delay it and do it towards the end of the 30 months and then pay it. And the other point in time I think it hits people is when they go for a transplant. And then maybe it's helpful to have Medicare Part A and B when you have your transplant, especially if you are younger and are going to lose insurance through an employer at some point, or may, if that's something that might happen for you. Having Medicare down the road to help cover that if you do need a transplant in the future is very helpful. And then trying to remember everything. I think the pediatric question, if I think it was Sandra, if you want to say more on your question, but kids are eligible through Medicare under their parents' work quarters. And similarly, spouses can provide work quarters for their spouse. So if you have not qualified yourself, perhaps under your spouse would be something to look into. If you're a child, seeing if you can qualify under your parents is a good way to start. If you are just entering the workforce and you're younger but older than qualifying under your parents, it is kind of scaled, and there is a chart online. You can look and see how many work quarters you need based on your age. So again, kind of a lot of real nuanced things to consider there, but hopefully that answers that. I'm trying to think of you mentioned one more, Emma. I'm sorry, my mind.
I think you touched on it was, if you don't have enough working credits, if you could still be eligible.
And again, I had to look this up. I think, the answer is yes, but it would be a unique situation. I think was what I had found. I'm trying to see what I wrote in here to myself. Yes, it's possible. It sounds like you can pay more for it. I honestly don't personally know anyone who's ever done this, so I'm not sure I can speak from experience, but it is possible is what it says. I think it's probably not very common, and I don't know if the cost burden with the additional fees would be as effective as perhaps, again, buying like a private plan or sticking with one through your employer. So I think that would probably need to be on an individual basis.
Okay, thank you. A few questions about if they are fully covered through another insurance like the VA, do they still need to apply for Medicare? And then a follow-up question to that is if they're still working, Part B can be expensive. So should they apply and obtain Part B so they don't have the lifetime penalty, or can they wait? So three-part question there. First, if they're fully insured through like the VA or maybe their work insurance, do they need to sign up for Medicare when they become eligible?
I think the VA is unique. Marissa, do you know more about this, or do you want me to
Yeah, I think that the VA, again, like Kelly was saying, is very unique. And if you do then want to seek services outside of a VA hospital for something like a transplant, it might become a challenge. I think it will depend if, the coverage is TRICARE or something. Sometimes there are restrictions with the VA coverage, that they may only be able to receive coverage through VA centers. So that's just something I've encountered in the past. But do they need to apply for Medicare? Again, I think that's an individual decision. If you do need it in the future and you haven't applied, you may still face those penalties.
Thank you. And we had an individual, one of our CMS cores out of the VA as a benefit as opposed to an insurance. So that can be one way of thinking about it. Thank you, Jim. So lots of questions, and a lot of this may be something that you can discuss with your insurance coordinator around if they're working and they have an employer insurance coverage, will they still be charged for that late enrollment if they don't need to have the Medicare?
So say one more time, would they be charged a fee if they didn't need the Medicare?
Correct, because they have insurance through their employer. So they don't necessarily need the Medicare, but will they have like a lifetime penalty?
Yes. So if it's through their employer, yes. If it's through the Affordable Care Act, no, I believe. But through your employer, it's like you're choosing not to because of that coordination of benefits. So at 30 months, your employer will probably say, you're eligible for Medicare and we're not going to pay for your dialysis anymore. And you might be kind of forced your hand with the employer because that's kind of the agreement that they've made between these private insurance companies. Like I said, for like the longer term down the road is where I've seen like people who have had kidney disease for many, many years, and there's some transplant down the road. They didn't think they needed Medicare, and then down the road for a transplant, you want it, and then they're paying a lot, kind of retroactively to have it cover immunosuppressant medication or other things associated with the cost of the transplant. I think those are kind of the longer term things that people don't consider.
And to Kelly's point, I mean, I have worked with patients that this has come up and they didn't want to take the Medicare, and then they go to actually get evaluated from the transplant center. And when they find that out, the transplant center says, your insurance isn't really stable, because you don't have this and you're going to end up paying so much money. We're worried you're not going to be able to afford all the immunosuppressant medications. So it is something that, they want to make sure this isn't going to be a huge burden in the future as well. So it's kind of like thinking about the long game.
Which can be hard to do. We acknowledge.
Yeah, for sure.
I think with all of this, that's kind of, there's so much nuance in insurance in general when we're talking about deductibles and copays and co-insurance. Like it's hard to know what your true cost will be in any given year as your health care changes, as the medications you take changes. And then, even being mindful that some of these plans may differ on the type of providers you can see. So there's just so many things to think about and to weigh what's most important to you when it comes to the providers you see. And then B, trying to think through, would it be cheaper to pay something more a month to have greater cost sharing from your insurance plan? Versus paying less per month, but maybe paying a ton more for certain medications. And so those are things that sometimes we live and learn, right? And have the opportunity to correct year over year when open enrollment occurs for, say, Medicare Part D. But for others, they maybe kind of have limited options through employers, et cetera. But lots of things to think about with very individual, nuanced considerations.
Absolutely, thank you. There was actually a question there specific to transplant around individuals who have Medicare Advantage plans. They're getting worked up with a transplant center, and then the new year comes and they're no longer contracted with that hospital. you're shaking your head. I can see you've seen that before. Do you have any tips and tricks on that, or suggestions, or what you've seen that works well in those scenarios?
I mean, I haven't encountered this personally with anyone that I've worked with, because Medicare Advantage plans really only became eligible for kidney patients to join after they were diagnosed just a few years ago. I think this is why you really need to be careful with what plans you join, and especially when you end up, looking at things that are going to become in network, not in network. You don't know that information in advance, and if you're in an area where there might not be a lot of choices for, changing transplant centers, you might live in an area where there's only one or two transplant centers versus a larger area, I think you have to be careful. Again, switching out of those plans can be difficult. So Kelli, I don't know if there's anything else you have to add to that.
Yeah, I think this is something we tread lightly around. I think so, we try to present them as kind of equal options and that there's considerations for both. But to Marissa's point, I think the Medicare Advantage plans, it is fairly new still that they are available for people with who are on dialysis or have a transplant. So there's still some things I think being worked out there. And I think the nuance of provider has become a major issue for people, which you would not have that problem if you had traditional Medicare with a supplement plan. So if that is a very important thing to you, I think that should be a huge consideration, maybe even over cost for you and your family.
Wonderful. Thank you for addressing that.
And yes, to Lori's point, also having dialysis centers that may be out of network as well. That can definitely happen. It can really happen with any provider.
Any provider. We're hearing it kind of across the board. I think this has been the biggest challenge with Medicare Advantage plans that we hear.
Yeah, and Laura, having patients who are listed and then do have to change, I think also the providers at the transplant centers, they don't know if they're going to be in network from year to year, like the actual doctors, nurses, coordinators, everyone. So wanting to make sure that, their patients are in the best spot possible to be able to have continued care and, be able to stay on the list as well.
Thank you. Absolutely. And Marissa, there was another question that came up when you were discussing post-transplant. The question was, do you still have to reapply for the immunomed coverage?
I believe that you do. I think that you need to make sure that you're speaking with your post-transplant coordinator or the financial coordinator, but certainly making sure that, you let them know I still need this. I still need this coverage, especially since it's just for the immunosuppressant meds. There's going to be specifics that they need to make sure that I would hesitate to just assume that you're going to roll over into it.
Thank you. And one other question, someone mentioned that they heard that Part B can now become effective the month after you apply for Part B during the open enrollment and may not need to wait until July. Do you have any information on that change?
I was not aware of that, but things could happen that I'm not aware of also.
Understandable.
Yeah. And then are we able to send those websites out to you? Emma, are these slides going to be open for everyone?
Yes, thank you. We will post these slides after the 2-day event concludes onto our website. So we will make sure all attendees have access to those and know where to find them. We also can drop some of those links into the chat now as well. So thank you.
Thank you.
Marissa and Kelly, thank you so much for this amazing information. I know insurance is one of the biggest obstacles and barriers for anyone really, but especially for those within the ESRD community.